regarding some patient in the surgical ICU with the following strips noted on a telemetry monitor. So I'm going to give you the information you need to solve the problem. I'm telling you they have a biventricular ICD, and I'm giving you this strip. And then there's going to be a multiple choice question about what's going on here. And then I'm going to ask you, how do you fix this? So the question I think you may have in your book, that's what is going on? What's the mechanism of the electrocardiographic abnormality? The mechanism of the electrocardiographic abnormality. And we're going to go back and look at it. And I'm going to ask, unless somebody wants to volunteer, we'll give it to a table, that one of our tables here. How about you all? So look at the tracing and all tell me what you think is going on. We'll give you a minute or two.
No, I know.
Remember, it's a surgical resident. They don't know anything about pacemakers, so.
Premature. He just not sensing anything. But it's
Two people, Ken. You had two takers.
Okay.
Not very good.
No.
Come on, vote. Analyze and vote. By the way, when you take boards, you get no more than about 2 minutes per question. Yeah. And that's still about the same, 2 minutes per question, I think.
That's the answer.
No, I'm not going to be the dummy twice.
George. What did he say? He looked at the answer. He said, I'm not going to be the dummy twice in a row.
I didn't even see the thing. I'm sorry, I was putting my stuff together.
Okay, somebody come up and take a stab at it or do it from there. What do you see? What do you think is going on? What does that table think?
Okay. I'm not sure if this is on. Okay. So it seems like starting at the top of the strip, the first P wave is not sensed.
Which P wave?
Right after the first paced
That P
ventricular
wave?
beat.
Okay.
And then there's a paced P wave, and then a bi-V pacing capture, and then the sensed P wave, another bi-V pacing, and then it seems like another undersensed P wave, and then another paced capture beat for the atrium.
So does this look right? Does this look right?
No. So
Okay.
First concern is undersensing for atrial capture, or for atrial sensing.
So there's a problem with atrial sensing. Is it a problem with the atrial lead, or is it some sort of functional problem? How would you figure that out?
There could be, I guess theoretically, you could have different amplitudes for the
In front of us, please.
P waves.
Thank you.
Say that again?
You could have different amplitudes for the P waves. So if there's some variability there with the setting,
Sure.
it could be functional.
Do you think it's functional?
I guess because of the intermittent.
It's intermittent, but is it functional, or you think it's a problem with the atrial lead? Yes, a problem with the atrial lead, or no?
Unsure.
Okay. So remember I said when you approach a tracing, try to figure out what's going on, what's pacing, and what's not. So if you have A pace, V sense, A pace, V, I'm sorry. If you have A pace, V pace, A pace, V pace, What does that tell you? It tells you you're probably at your lower rate limit. Sure, you can have rate response on, but the patient's lying in bed in on ICU. So you could go from the V pace to the A pace, right? And that would be the escape interval, because if there's something sensed, it should track it, right?
Right.
So let's go here from the V pace to the A pace, right? We get over here. So let's go backwards and go to the lower rate limit here. Here's the V pace, and go backwards. And where do you end? Where does that land me?
It's before the other P wave.
Huh?
Or it's
What is that? Electrocardiographically? Right on the T wave, right? Right? So if I go V pace to A pace here and go from the T wave to A pace, the numbers are perfect. Remember, measure twice, cut once, measure that. You can measure the VA escape interval and find out what is being sensed, right? Or you can go from the the V pace to the V pace, figure out what's being sensed. So what's being sensed? The T wave is being oversensed. Here is how you do it. In blue is the lower rate limit, right? And then what is the lower rate limit made up of in a pacemaker? This is where just a little bit of knowledge about what's going on with a pacemaker. You have from the pacing spike, from the ventricular pacing spike, you have a VA escape interval followed by an AV interval. That's what the lower rate is made up of. And if you go backwards, you see where the VA interval is. And where does it time out to? It paces, but it's sensing something here and it's resetting the timing cycle. So they, in fact, did pick up a problem with this biventricular device, and that was called T-wave oversensing. So how would you get rid of T-wave oversensing? How are you going to fix the problem? Simple. What are you going to do?
So I heard it.
You're going to program, change the event. What?
You could increase the PVARP, and it wouldn't wind up pacing based on the ventricular activity.
That's not going to help that much. What's the real problem? Speak up.
Increase the ventricular sensing so that the fence goes up and then the T wave will not be.
You're going to change the ventricular sensitivity so you no longer sense the T wave. So you're going to program it, you're going to decrease the sensitivity, which means program it to a higher number. So bi-V pacing, pauses, think of oversensing, and the most common cause of oversensing in a defibrillator is T-wave oversensing. Okay, now this is a case I saw about a month ago. Somebody handed me this electrocardiogram. Actually, it was on my patient. What is going on here? Patient with a dual chamber pacemaker. You just pass the mic to a table to your right or left. You can pick. So the subject is, what's going on here? There are a whole lot of spikes here. It's a dual chamber Medtronic pacemaker. And I'm going to give you some information. You can look at the EKG, but the next slide tells you how the pacemaker is programmed. So it's a Medtronic dual chamber MRI conditionally safe pacemaker. You notice there's a left bundle lead in there, a Medtronic 3830, a Medtronic lead happens to be the 3830. It just happens to be in the left bundle. And this is just my personal preference. All the device settings, program settings are in this slide. And look at this, device is not that old. You can see this happened about a month ago, put in December. Lead impedances are just absolutely perfect. Thresholds are perfect. RV threshold, R wave amplitudes are perfect. So what's going on with this perfect pacemaker and this stupid EKG? Any takers? Good. Okay, give him the microphone.
To me, it looks like that the heart rate is pretty much regular. And the first thing that comes to my mind is how far away each spike from, like in some spikes, they're really close to each other. I don't think the pacemaker works that way. So it comes to my mind that this could be an artifact.
It'd be what?
An artifact.
So you think these spikes are artifact? And you would be correct. So we're going to talk a little bit about spikes. The blue arrows indicate atrial pacing spikes, okay? The atrial pacing rate happens to be about 63 beats a minute, right? Because there are a couple of reasons why, right? The lower rate is programmed to 60. And, well, if you have DDDR on, the rate can be a little bit higher, but modified atrial-based timing will allow your lower rate to be a little bit higher based on your AR interval. So the orange arrows indicate unexpected EKG machine artifacts. How does a digital EKG machine give you this artifact? Anyone have any idea? George, you have anything to say about digital EKG machine artifacts?
And when you're talking, I'm being very careful.
And I have nothing to say.
Well,
We're not
Taking the
we're not
fifth.
stepping into one of your things, Ken. We've learned too much about you.
But I look at it simply like they're either, not every spike is a pacemaker spike. And there's nothing there that remotely suggests that it has anything to do with the implanted system. So it could be a clanging lead, another redundant lead, or it could be something outside.
so it's nothing like that. There are no leads outside. There are no clanging leads.
It's just, who cared though, right? No, I mean, I looked at it from a more practical standpoint. I looked at this and I said, it's just artifact. Who cares?
It is artifact. It is.
I don't know why it's there. I'm going to let you tell me.
Yeah, well, I think, we're always told that digital EKG machines, the beauty of digital EKG machines and digital monitors are that they, digital recording devices like Biotel monitors, whatever companies monitor, but is that, well, you have digital thing, it shouldn't give you any artifact. But I've seen it in a number of patients. I've yet to have an engineer give me a satisfactory explanation. So I went back to the manual, and this is the best that I could find. They said, is there any problem related to the EKG machine? That's the EKG machine I was using all day long, plenty of patients coming in with pacemakers. It really is unexplained. The pulse width on a pacemaker is typically about 0.4 milliseconds. And of course, a lot of how big the artifact is, somebody brought up how big is the artifact, will depend upon the sampling rate of EKG machines. They're fairly standard. So I don't know. I think it must sense something and then must produce an artifact, amplify whatever the signal is that it senses, but I have no idea where it comes from. It was not a problem with this patient's pacemaker, and you see it extraordinarily rarely. But the important thing to know is the physiology, that is, there's no pacemaker, there's no reason unless it's some sort of algorithmic thing coming out of a pacemaker for the spikes to be all over the place like this, like that. Now this, on the other hand, is of historical import. or actually, this is history, since we've heard a lot about history today. What about this pacing artifact? What do you think about this? Does anyone remember what this was? This is from about 10 years ago, an EKG from about 10 years ago. I bet you nobody in this audience will remember, but I'll give you this clue. This pacing spike is about 185 milliseconds, and it seems to be primarily in the end of the QRS ST segment. So this is, Medtronic should know. Somebody from Medtronic know the answer to this? This is a special Medtronic therapy that was developed for congestive heart failure.
Oh, come on.
Oh, come on. I had to show one where
You kidding me?
cardiomyoplasty, skeletal muscle wrapped around the heart connected to a pacemaker.
How well did it work?
Didn't work so well. It was abandoned, but I thought you should see the EKG because life wouldn't be fun if we didn't give you a variety of spikes going all over. So here's another example of a pacing artifact. Here we see there's a pacing spike in the QRS. Now that pacing spike should be in the absolute refractory period of the QRS, right? Everyone agree? I mean, you can't really capture ventricular myocardium during the inscription of the QRS. That'd be the absolute refractory. And you see the pacing spike is a little bit wider than what you're used to. And this is an example of a pacing spike from the cardiac contractility modulator device. Duration's about 20 milliseconds. OA is going to be in the QRS during the absolute refractory period, and that's a little bit what that would look like. Now, here's another one, another pacing spike one. And this will be the last one because Eric's really going to complain about this one.
Like I didn't on the other two?
Okay. This one was actually, we were actually called to the emergency room for this a patient who was obtunded about a pacemaker malfunction. And
I bet you I know what it is.
I bet you do.
Okay,
I bet
I
you
didn't
do.
see that. It was hard to see that thing.
Hard to see the spike, but
Yeah, it was hard to see the spike.
it's there.
There it is.
And it's
Okay.
a very low rate. You know what it is. I bet you do.
I don't know. I just know it doesn't need a pacemaker. Reps get really mad when you get called to the ER at 2 in the morning because the pacemaker isn't working and the patient's in AFib going at like 100 a minute. and they'll do it. I know this because my son was rep. He doesn't do that now. He's into ablation. And he would call me and say, Dad, would you talk to this ER doc for me? and I'd talk to the ER doc. I'd say, look, when you're going 100 a minute and the pacemaker lower rate 60, you're not going to see spikes. I said, check in the morning. It's okay. Check in the morning, you know? So this person is not needing the pacemaker.
Right.
That's all I can tell you.
So, and the spike rate is really slow, right? So that I looked at the EKG and said, Jesus, my gosh, this spikes are like at 30 beats a minute, 20 beats a minute. I said, wait a second, show me the X-ray. So what kind of pacemaker was this? This was a gastric pacemaker. And gastric pacemakers, the pacing spike's unrelated to the EKG.
I did not know that. I'm going to fess up.
So there it is. So you got simple stuff.
Is such a thing as a gastric pacemaker?
Yeah, for
what?
motility. For motility.
And it's
Same
what?
thing.
And what is
There
it? Every.
colonic pacemakers also.
I mean,
for
what is the
motility.
rate you're supposed to set them at? Just so
30. They're set at a very slow rate because it's the rate of peristalsis, I guess.
all day long, 30, or does it come on and off?
I don't know. That's a good question. And they have bladder pacemakers. They have every type of pacemaker you can imagine. So
I did not know that. So I know he gave me a lot of credit. I'm going to fess up with you. I did not know that. All I noted was he didn't need a pacemaker.
So just a thing on spikes. So you've seen something like this before. I'm showing you an EKG, some rhythm strips, and then
Reps get really mad when you get called to the ER at 2 in the morning because the pacemaker isn't working and the patient's in AFib going at like 100 a minute. and they'll do it. I know this because my son was rep. He doesn't do that now. He's into ablation. And he would call me and say, Dad, would you talk to this ER doc for me? and I'd talk to the ER doc. I'd say, look, when you're going 100 a minute and the pacemaker lower rate 60, needing the pacemaker,
Right.
that's the only I can tell you.
So, and the spike rate is really slow, right? So that I looked at the EKG and said, what kind of pacemaker is this? So you got pacemakers also.
I mean, what,
They have bladder pacemakers. They have every type of pacemaker you can imagine. So
I did not know that. So I know he gave me a lot of credit. I'm going to be fess up with you. I did not know that. All I noted was he didn't need a pacemaker.
So just a thing on spikes. So you've seen something like this before. I'm showing you an EKG, some rhythm strips, and then put the magnet on, and what happens? What happens to a pacemaker when you put a magnet on it? Everyone should know the answer. What happens? It paces asynchronously, DOO, VOO, depending on the type of pacemaker, AOO. So what is the difference between the top and the bottom? What have you fixed by putting a magnet on the pacemaker? Correct. From where? Excellent. Perfect. This was another ventricular lead failure in insulation, and this is just the tracing showing some oversensing on the intracardiacs. Okay. Oops, did I go? So what's going on here? There are asterisks and triple asterisks and just look at the tracing on the board. Tell me what's going on with the asterisks, single, double, triple. If you get all three of the asterisks right, you get a copy of Eric's book, Eric and George's book, or my pacemaker book, since it's a pacemaker.
Yeah, why not give him your book?
Yeah. Okay, come on up. Come on up and talk me through this.
Not sure I can explain all of them, but I'll give it a go.
What's really nice about this, and I like from a practical point of view, is that ECG, you see the atrial spike is big, the ventricular spike is big, and they're in different directions. Makes life a little easier, doesn't it?
Yeah.
If you just had the ECG.
Yeah.
So I think I'm using this term correctly. I think this is hysteresis to see if we have AV conduction in some sort of ventricular pacing reduction algorithm, MVP, VIP, whatever. And so we have A pace, V pace on the top strip.
Perfect.
And then
With capture of the atrium and capture of the ventricle, even though the P wave's not gigantic.
very small, but I'll take your word for it. And then the first three QRSs are
That's
A pace,
always
V
a
pace.
good idea.
And then here we have A pacing, and if I remember correctly, Medtronic's algorithm allows for one or two dropped beats.
But which one is it?
Excuse me, not dropped beats, non-conducted beats.
See that? See that? God, I'm telling you, man.
That was very good. He really liked that.
I'm very.
I call myself. I caught the
very
dropped beat wave.
excited.
So let me ask you a quick question. Where do you think where does this QRS come from?
I wonder if this is just slow conduction down here,
Okay.
or if this could be some sort of escape beat.
So if it's slow conduction, then what can you say about the atrial pacing spike? It had to have
It
captured the
captures.
atrium.
Yeah, it captures.
So you didn't have to take my word for it, right? You have
Yeah.
that here. You can't conduct to the ventricle unless you capture the atrium, right? Unless this just happened to be a ventricular escape beat. Okay. So then what happens
And
on the
then
next beat?
we have a V-sense here, presumably, with normal function, and then we A-pace again, and we wait to see if there's conduction to the ventricle.
And there's not.
And there's not. So then what we have is ventricular safety pacing at, I think it's about 110 milliseconds here.
Okay, hold on. Really good until here. This
Oh,
is
no.
part of the algorithm. It's AV pacing, but the AV interval is 80 milliseconds.
Okay.
Safety pacing is something completely different, and we'll get to that in a minute, but that's good because we'll talk about it. What happens here?
So here we pace the atrium again, and we get delayed conduction to the ventricle.
So we know we're capturing the atrium.
Yep. And then pace the atrium with no conduction to the ventricle. And then we resume
Backup pulse.
A pace, V pace.
Now what happens here? Triple stars.
So my eye calipers tell me that the A pacing is on time and regular at the
The
lower
VA
rate limit.
escape interval. You can just do that. and do that. Here's your VA escape interval. Pretty close.
Yep. And
So
then
that's an atrial spike here.
So a couple things might have happened in my mind, I think. Either the atrial lead fell into the ventricle and paced the ventricle, which is very unlikely. The atrium doesn't see that, paces the atrium anyways, probably captures. And then we have V-pacing because the PVC falls in the atrial blanking period. And so then the device tries to pace the ventricle because it doesn't
So
see
what
it.
happens when a PVC or an R wave, a conducted R wave, falls into an atrial blanking period? If you were a pacemaker, you want to make sure someone's not asystolic. So what do? You V-pace. And what is that called? Safety pacing. You V-pace with a short AV interval. Why do you V-pace with a short AV interval and not the programmed AV interval? Is because you don't want the ventricular pacing spike to end in the T wave, to line up in the T wave. So to avoid proarrhythmia, which, although it may be rare, if you can do that. So this is safety pacing. Safety pacing is different numbers for different companies, different devices, different times. Pretty consistently for Medtronic, it's been 110 milliseconds. And then devices, if you fail in 2 out of 4 consecutive beats, then you switch modes. So here it is.
Can I give you calipers? I mean, you make some measurements for me. Oh, go back. Can you go back?
Yeah.
Because I'm going to put my foot in this right now. Would you measure the stimulus to QRS on the starred beat?
This one here?
Yes, sir.
Okay.
Would you measure the stimulus to QRS down here on the left?
Oh, it's shorter.
I think this is AFib. Look at the baseline. Isn't that, maybe, I don't know. It just seems, I don't see any good solid P waves. Even the pace things, I mean, it doesn't look like it's really captured. It's like flat. Look at the second one up there, the stimulus. I mean, the spikes are still the spikes. I just don't personally think there's I just think it's, I mean, like I said, I may get murdered. I would have called this AFib. I mean, all the spikes, the thing you said is still, is the thing you said. I just personally don't think you're capturing the atrium because I think the patient's got underlying fine AFib.
Yeah, well,
it's just the spikes still are the spikes and where they are for the reason they are, but I don't think you're capturing atrium, frankly.
Okay. And if that were to be
slide,
true,
he has the last word. Though.
Yeah, it's his slide. He gets the last word.
Yeah, the patient was in sinus rhythm. Yeah.
Well, show me sinus rhythm. Look at all that junk.
Okay.
Kenny, go back. You can't just say no. Look at that. Show me a sinus beat. Show me one sinus P wave in there.
Intercardiacs were good atrial electrograms.
All right.
You did a great job.
I can't argue with that. But I'm just telling you, if I were reading this, I don't have anywhere near your sophistication. I'm just going to fess up like George did before. You know, I'd look at this and say, I don't see a P wave there. Like this is like flat. You know, I don't see a P wave there, and I'd start to wonder personally, am I really capturing anything? Just me. And then I look down here and I say, look at all these little squiggles, these little.
To this table.
This table or this?
That table. Yeah.
Where we at, Ken? In your.
Yeah, I moved him around.
Oh, you moved them around. Oh, you moved them around, George.
Okay, so taking a look at the top strip at implant, first things that I see at the top, just the pacemaker spikes that are going across, do not seem associated with the QRS complex that you're showing me there. So it looks like you have atrial pacing, and then I don't think I clearly see a ventricular pace unless that's a portion there of what's blurred in. Is it?
Yeah.
Dr. Elma, okay, so then that's ventricular pacing that you have there that's following it. So that's AV sequential pacing.
A-pace, V-pace.
A-pace, V-pace that you see at the time of pacemaker implant. Second strip down looks like a telemetry strip. You have lead.
And again, because it's digital, you may have to look at it differently, but you can see ventricular pacing spikes on the bottom.
Okay,
tracing.
for the bottom one as well.
Are you convinced?
Yeah, I'm convinced. So know you have at least a dual chamber system, and it had the ability to pace A and V at the time of implant. That's what you're showing with that top strip. The second strip that you see, assuming that's going to be a telemetry strip from overnight, 2 channels, you have 2, and then one of the V leads over here. One of the things that I see here, or the appreciation at least, is that there's a narrow QRS in comparison to the ventricular pacing that you had at implant that showed a wide QRS. So a portion of what I would see here is this would likely be native conduction, at least for the QRS complex, as opposed to when you were ventricular pacing at the time of implant.
Okay, so what's going on? I agree this is native conduction, but what are these spikes doing?
Yeah, so as far as what the spikes are doing, one of the portions to consider is, could this be telemetry artifacts? So I'm going to follow it along, kind of starting all the way at the leftmost side of the page. That initial spike, I think I see a P wave right after it, the one just over your left shoulder, Dr. Ellenbogen. Is that right, or is that just part of the, nope, just over to the right of that. Is that a spike and then?
Ken, I'm going to try to follow along. Which one are you talking about? This one?
No, sir. Just outside of the amplitude axis measurement.
I don't know. It's hard to say what's going on there.
Yeah, so I can't tell definitively.
You don't need that.
Okay. So the first beat at least comes before that. Don't definitively see atrial capture or ventricular capture after that pacing stimulus. Next thing that I see is what looks like a native QRS complex, native P wave followed by a native QRS complex. And I see that on both of the 2 leads. That's that one there, yep. Then again, I end up seeing a spike that's put in. Then again, if you take a look, again, P followed by a native QRS. And then similarly, as you march down, I think I see P's followed by native QRSs.
What happens here?
Yeah,
The one thing that you end up, sorry, can you show that portion again?
You have this thing you didn't mention. Is that what you wanted to see? I'm just trying to follow you.
Yep, keep on going there.
So
yeah.
if you take a look and just measure spike to spike, is your spike to spike interval normal, Dr. Ellenbogen? That's fixed throughout the strip.
Yeah, you can measure.
Okay. So if the spike to spike interval
Come up here and measure for yourself.
I'm going to trust you, sir.
I'm going to circle something up here for you.
Okay.
Yeah.
Yep. So that's the portion of where it says 6 sinus syndrome was the reason why it was implanted. So, fair enough.
So is there one beat comes early in the middle of the bottom tracing?
Yes, it's the 1, 2, 3, 4. It's the 5th beat that ends up coming early.
And how come it comes early?
So that portion at least looks like once you have a pacer spike, I think you're capturing a portion of the P wave, and then you have a QRS that ends up following it.
That conducts.
Yes.
This one?
Then the next one after that, I do see the pacing spike again, but I don't see that you actually capture the atrium.
Yeah.
And similarly, no conduction down to the V, and then it looks like, again, you come back with sinus rhythm until the second to the last spike, where again, it seems to me that you are capturing the atrium and then conducting down to the ventricle.
So let's see what's going on. Here are the